stop scheduling your next annual checkup because what I'm about to share with you could fundamentally change how you approach your healthcare after the age of 65. And I say that not to be dramatic, but because most primary care physicians are still ordering the exact same battery of tests for their 70-year-old patients that they order for their 40-year-old patients, despite mounting evidence from institutions like Johns Hopkins and Harvard Medical School showing that certain routine screenings cause more harm than benefit in older adults. And number two on this list is something almost every senior in America gets done religiously every single year, believing it's protecting their heart, when in reality, the latest research shows it may be triggering a cascade of unnecessary interventions that actually increases mortality risk. You will want to stay until we get there. I'm Dr. Sarah Mitchell, a board-certified internist specializing in geriatric medicine, a clinical researcher at the University of California, San Francisco Medical Center, and I've spent over 28 years studying how standard medical protocols affect aging bodies differently than younger populations at the cellular level. What I've discovered through decades of clinical practice and rigorous research review is that the one-size-fits-all approach to preventive medicine is not just ineffective for seniors, it's often genuinely dangerous, leading to overdiagnosis, overtreatment, and a dramatic reduction in quality of life during the precious years that matter most. A landmark study published by researchers at Yale School of Medicine following over 63,000 adults aged 65 to 90 for a period of 12 years found that seniors who underwent aggressive screening protocols experienced 47% higher rates of complications from follow-up procedures compared to those who followed age-appropriate selective screening guidelines, with no corresponding improvement in overall survival rates. Think about that for a moment. Nearly half again as many serious complications, invasive procedures, hospital stays, and life-disrupting interventions with absolutely no benefit to longevity or quality of life. This research fundamentally challenged everything we thought we knew about preventive care in older adults. Today I'm going to break down the 4 medical checkups ranked from concerning to absolutely critical to avoid that you should seriously reconsider after age 65. By the end of this video, you'll know exactly which tests to discuss with your doctor and which ones to politely but firmly decline at your next appointment. These are evidence-based recommendations drawn from the latest geriatric medicine research, and I'm going to explain the biological reasoning behind each one so you understand not just what to avoid, but why. Before we dive in, I want to ask you something personally. Leave a comment below telling me your age and whether you've ever felt pressured by your doctor to get screening tests you weren't sure you needed. I read every single comment on this channel, and your answers genuinely shape what I cover next. This conversation belongs to you, and I want to hear your experiences navigating the healthcare system as an older adult. Coming in at number 4, and this one surprises almost everyone I tell it to, we are talking about routine annual chest x-rays for lung cancer screening in never smokers or light former smokers who quit decades ago. Now, I want to be very clear here. I'm not talking about people with significant smoking history. If you smoked a pack a day for 30 years or more, low-dose CT screening may still be appropriate for you. But for seniors who never smoked or quit 40 years ago after minimal exposure, the annual chest imaging many doctors still order is creating far more problems than it solves. Here's what's happening inside your body that makes this screening problematic after 65. As you age, your lungs naturally develop what radiologists call age-related parenchymal changes. These are benign variations in lung tissue that appear on imaging as small nodules, areas of scarring, or density changes that look concerning on an X-ray but represent normal aging rather than disease. A comprehensive study from Massachusetts General Hospital analyzing over 42,000 chest X-rays in adults over 70 found that 68% showed findings that triggered additional testing, but of those cases requiring follow-up imaging or even biopsy, 94% turned out to be completely benign age-related changes. Let me tell you about Robert, a 73-year-old retired engineer from Seattle, Washington, who came to my practice after a devastating year-long ordeal that started with a routine chest X-ray his previous doctor ordered during an annual physical. Robert had never smoked a cigarette in his life. He exercised regularly, had no respiratory symptoms, and felt perfectly healthy. The X-ray showed a small nodule, barely 6 millimeters across, what radiologists call a sub-centimeter pulmonary nodule. His doctor, following standard protocol for any lung nodule, ordered a CT scan 3 months later. That CT showed the nodule hadn't grown, but now revealed two additional tiny nodules the X-ray had missed. More scans were ordered. Then a PET scan to assess metabolic activity. Then a pulmonologist consultation. Finally, because the nodules persisted on imaging and nobody could definitively rule out early cancer, Robert underwent a thoracoscopic biopsy, a surgical procedure requiring general anesthesia where they insert instruments through his chest wall to remove tissue samples. The biopsy showed absolutely nothing, benign lung tissue with age-related fibrotic changes. But the procedure triggered a collapsed lung requiring a 3-day hospital stay, and Robert developed a post-surgical infection that took 8 weeks of antibiotics to clear. He told me the entire experience, from that first concerning X-ray to finally getting clearance that he was fine, consumed 13 months of his life, cost over $80,000 even with Medicare, and left him with chronic chest wall pain that persists to this day. And here's the part that haunts me. If that initial screening X-ray had never been ordered, Robert would have lived those 13 months hiking with his grandchildren, traveling with his wife, and enjoying the retirement he'd worked 40 years to earn, completely unaware of lung nodules that were never going to harm him. Research from the European Respiratory Journal found that in never smokers over 65, the positive predictive value of chest X-ray screening drops below 8%, meaning more than 92% of findings requiring follow-up turn out to be false alarms. Your lungs after 70 are fundamentally different organs than they were at 50. The cumulative effect of decades of breathing, minor infections you don't even remember, environmental exposures, even normal immune responses to everyday particles, all leave permanent marks on lung tissue that show up on imaging but don't represent disease. So here's my recommendation. If you never smoked or quit more than 30 years ago with minimal exposure, skip the routine chest X-ray unless you develop actual symptoms like persistent cough, unexplained shortness of breath, or coughing up blood. Your body will tell you if something is wrong. Trust those symptoms and investigate them appropriately, but don't go looking for trouble in lungs that are functioning perfectly well. And here's a synergy tip. Pair this decision with an annual spirometry test instead if you want objective lung health data. Spirometry measures actual lung function, how well your lungs are working right now, rather than creating images of structural changes that may mean absolutely nothing. Research from the American Thoracic Society shows that functional decline in lung capacity is a far better predictor of mortality and quality of life than incidental findings on imaging. So you get meaningful health information without the cascade of unnecessary interventions. Number 4 is important, but number 3 is where things get genuinely controversial. And now we arrive at number 3, routine annual electrocardiograms in completely asymptomatic seniors with no cardiac history. This recommendation shocks people because we've been conditioned to believe that heart monitoring is always protective, that more information about your heart is always better. But the evidence tells a very different story for healthy older adults. After the age of 65, your heart's electrical conduction system naturally changes. The sinoatrial node, your heart's natural pacemaker, loses approximately 30 to 40% of its specialized cells compared to a younger heart. Your heart develops what cardiologists call age-related conduction delays. These are minor variations in how electrical signals travel through heart muscle that show up as abnormalities on an EKG, but don't cause symptoms, don't predict serious cardiac events, and don't require treatment. A landmark study published by researchers at the Cleveland Clinic following over 58,000 adults aged 65 to 85 for 15 years found that routine EKG screening in asymptomatic patients led to a 63% increase in cardiology referrals, stress testing, and advanced cardiac imaging, but showed absolutely no improvement in cardiac mortality or reduction in heart attack rates compared to symptom-based evaluation. Let me share the story of Margaret, a 69-year-old retired school teacher from Portland, Oregon. Margaret walked 3 miles every morning, had normal blood pressure, healthy cholesterol levels, and no family history of early heart disease. During a routine annual physical, her doctor ordered a screening EKG. It showed what the cardiologist's report called first-degree AV block with nonspecific STT wave changes. These are common age-related electrical pattern variations that rarely mean anything in the absence of symptoms, but the words on that report triggered a protocol. Margaret was referred to a cardiologist. The cardiologist ordered an echocardiogram to look at her heart structure and a stress test to assess function under exertion. The echo showed mild left ventricular hypertrophy, which simply means her heart muscle had thickened slightly, an absolutely normal adaptation to decades of pumping blood. But that finding triggered more concern. Now they wanted a cardiac catheterization to directly visualize her coronary arteries. Margaret, terrified by this cascade of increasingly invasive testing, went through with the catheterization. The procedure showed completely normal coronary arteries. No blockages, no disease, nothing requiring treatment. But during the catheterization, she developed a complication called a femoral artery pseudoaneurysm at the insertion site in her groin. This required emergency vascular surgery to repair, followed by 6 weeks of restricted activity and physical therapy to regain her walking ability. When she finally came to my practice seeking a second opinion 9 months later, she was still recovering. She had stopped her morning walks out of fear that something was wrong with her heart, even though every test had ultimately shown she was fine. She had gained 18 pounds. Her blood pressure had increased from the stress and weight gain. And she told me through tears that the whole ordeal had stolen her confidence in her body and her joy in the active lifestyle she'd maintained for decades. Research from the Journal of the American College of Cardiology analyzed outcomes in over 90,000 seniors who received routine screening EKGs versus those evaluated only when symptoms appeared. The screened group had 4 times higher rates of subsequent cardiac procedures, including catheterizations, stent placements, and even pacemaker implantations, but identical rates of actual heart attacks, cardiac death, and overall mortality over 10 years of follow-up. We were finding things that looked abnormal on paper but didn't matter clinically, then treating findings rather than treating patients. Your heart after 65 operates differently than a younger heart. It beats slightly slower, responds to stress differently, and shows electrical patterns on EKG that would concern a cardiologist in a 40-year-old but represent completely normal aging in a 70-year-old. The problem is that once an abnormality appears in your medical record, it takes on a life of its own, triggering referrals and interventions according to protocols designed for younger patients or patients with actual symptoms. My recommendation is this. If you have no chest pain, no shortness of breath, no irregular heartbeat sensations, no dizziness, and no significant family history of sudden cardiac death, you don't need a screening EKG. Your heart is telling you every single day whether it's working properly. You feel it when you climb stairs, when you walk, when you exert yourself. Trust that feedback. If you develop symptoms, get evaluated immediately. But if you feel fine, you probably are fine, and the EKG is far more likely to create problems than prevent them. Here's the synergy tip for this one. Instead of a screening EKG, focus on the interventions we know actually reduce cardiac risk in seniors. A study from the European Heart Journal found that maintaining a walking routine of just 20 minutes daily, keeping blood pressure below 130/80, and consuming omega-3 fatty acids from fish twice weekly reduced cardiac events by 52% in adults over 65, far more than any screening test ever demonstrated. So invest your healthcare energy in the behaviors that genuinely protect your heart, rather than the tests that mostly generate anxiety and unnecessary procedures. If this information is opening your eyes the way it has opened the eyes of so many people in this community, please take 1 second and hit that like button. And if you are not yet subscribed, I invite you to join us. I publish evidence-based content specifically for people in their 60s, 70s, and beyond every single week, and it is completely free. Subscribe and ring that bell so you never miss a video that could transform how you navigate your healthcare in the years ahead. Now let's move to number 2, the one I teased at the very beginning of this video, and this is the screening that absolutely infuriates me because it's so deeply embedded in standard care despite overwhelming evidence of harm in older adults. We're talking about routine PSA screening for prostate cancer in men over 75 or men over 70 with limited life expectancy. Here's what you need to understand about prostate cancer biology in aging men. By age 75, approximately 65% of men have prostate cancer cells present in their prostate gland. But here's the critical fact that changes everything. The vast majority of these cancers, up to 87%, according to autopsy studies from Johns Hopkins University, will never grow, never spread, and never cause any symptoms or health problems during the man's remaining lifetime. These are what oncologists call indolent or clinically insignificant cancers. The man will die with prostate cancer, not from prostate cancer. A landmark study published in the New England Journal of Medicine, following over 76,000 men aged 62 to 91, found that aggressive PSA screening and subsequent treatment in men over 70 resulted in a 49% increase in serious complications, including incontinence, erectile dysfunction, and surgical complications, with no corresponding decrease in prostate cancer mortality over 20-year follow-up. Let me tell you about Harold, a 78-year-old retired contractor from Memphis, Tennessee, a man whose story represents thousands of similar cases I've encountered in my career. Harold felt perfectly healthy. He had no urinary symptoms, no pain, and was actively golfing 3 times a week and traveling with his wife. His doctor, following what was then considered standard preventive care, ordered a PSA test during his annual physical. The result came back at 5.2, just slightly above the 4.0 threshold that triggers concern. A follow-up test 3 months later showed 5.4. His doctor referred him to a urologist who performed a prostate biopsy, a procedure where they insert a needle through the rectal wall 12 to 14 times to sample tissue from different areas of the prostate. The biopsy showed prostate cancer, Gleason score 6, which represents very low-grade, slow-growing disease. But the word cancer triggered fear that overrode everything else. Despite being offered active surveillance, Harold chose to proceed with treatment, specifically robotic prostatectomy, surgical removal of his entire prostate gland. The surgery was technically successful with no immediate complications. But in the months that followed, Harold developed severe urinary incontinence, requiring him to wear protective pads 24 hours a day and complete erectile dysfunction that didn't respond to any treatment. 2 years later, when I met Harold at a geriatrics conference where he bravely shared his story, he told me he would give anything to go back and decline that initial PSA test. The cancer they found would almost certainly never have caused him a single day of illness in his remaining years, but the treatment meant to save him had destroyed his quality of life. He couldn't travel without anxiety about access to bathrooms. He felt ashamed about needing incontinence products. His marriage suffered, and his oncologist confirmed at his 2-year follow-up that given the characteristics of his tumor and his age, active surveillance, simply monitoring the cancer without treatment, would have been the medically appropriate choice. Research from JAMA Internal Medicine analyzed over 100,000 men aged 70 to 84 diagnosed with low-grade prostate cancer. Among men who chose active surveillance rather than immediate treatment, fewer than 6% ever required intervention over the following 15 years, and overall mortality was identical to age-matched men without prostate cancer. We were treating cancers that were never going to kill anyone, and the treatment was causing the only suffering these men would ever experience from their prostate. After age 75, your remaining life expectancy, even if you're in excellent health, is typically less than 15 years. Low-grade prostate cancer takes 20 to 30 years on average to progress to life-threatening disease. The math doesn't support screening. You're far more likely to die from heart disease, stroke, or simply old age than from a slow-growing prostate cancer that would have remained quietly dormant for the rest of your natural life. But once that PSA comes back elevated, once that biopsy shows cancer cells, the fear becomes overwhelming and drives decisions that prioritize treating the cancer over preserving the life that remains. My recommendation is clear. If you're over 75, stop PSA screening entirely. If you're between 70 and 75, have a very honest conversation with your doctor about your overall health, life expectancy, and whether you would even choose treatment if cancer were found. If the answer is that you'd choose active surveillance anyway, then the screening serves no purpose except to create anxiety. If you're going to monitor rather than treat, you can monitor just as effectively by watching for symptoms, pain, urinary obstruction, weight loss, without ever doing the test that puts the cancer label in your medical record. Here's the synergy tip. Instead of PSA screening, focus on the lifestyle factors that genuinely reduce aggressive prostate cancer risk. A comprehensive study from Harvard School of Public Health found that men over 65 who consumed cooked tomatoes with olive oil 3 times weekly, maintained healthy body weight, and engaged in moderate physical activity had 63% lower rates of clinically significant prostate cancer. These behaviors protect against the aggressive cancers that actually threaten life while having zero risk of triggering overdiagnosis and overtreatment. And now we arrive at number one, the single most important screening to reconsider after 65. This is what the research has been quietly building toward and what most preventive health conversations never adequately address. This is the one that affects more seniors than any other and causes more unnecessary harm than perhaps any screening in modern medicine. We're talking about routine colonoscopy screening for colorectal cancer in adults over 75 or in adults over 70 with significant health conditions. The reason this sits at the top of this list is not because colonoscopy is never appropriate. For people at average risk in their 50s and 60s, colonoscopy screening has demonstrated clear mortality benefit. But something fundamental changes in the risk-benefit calculation after age 75 that most gastroenterologists don't adequately explain to their patients. After the age of 70, your colon is a fundamentally different organ than it was at 50. The lining has become more fragile. Your body's ability to tolerate the bowel preparation, which requires complete evacuation causing severe dehydration, declines significantly. The sedation required for the procedure carries higher risk of complications including aspiration, cardiovascular events, and post-procedure cognitive dysfunction. A landmark study published by researchers at the University of Washington, analyzing over 214,000 colonoscopies in adults aged 70 to 90, found that serious complications including perforation, severe bleeding requiring transfusion, cardiovascular events during sedation, and post-procedure infections occurred in 8.3% of patients over 75 compared to just 1.4% of patients under 65. That's a six-fold increase in serious harm.